Welcome to this Step 2 clinical knowledge review on sexually transmitted infections test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for sexually transmitted infections and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the infectious disease and reproductive sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for sexually transmitted infections. Second, we will apply specific strategies for questions about genital ulcers, urethral discharge, and cervical screening. And third, we will master the next best step question format for diagnosing and treating common sexually transmitted infections. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the ulcer versus discharge split. When you see a question about a genital complaint, immediately ask yourself, is this an ulcer or is this discharge? For ulcers, the key question is whether it is painful or painless. A painful ulcer with tender lymph nodes is herpes simplex virus until proven otherwise. A single painless ulcer with a clean base and firm borders is classic primary syphilis. For discharge, you need to look at the Gram stain. Purulent discharge with gram-negative intracellular diplococci means gonorrhea. A scant mucopurulent discharge with a negative Gram stain points to chlamydia. The boards absolutely love pairing these together, so make this your first mental framework. Strategy 2 is all about recognizing syphilis staging, because the boards test this in so many different ways. For early syphilis, primary stage gives you the painless chancre. Secondary stage gives you that classic diffuse maculopapular rash that involves the palms and soles, along with condylomata lata and constitutional symptoms. Whenever a question mentions a rash on the palms and soles, secondary syphilis should be at the top of your differential. For late syphilis, think gummers, aortitis with ascending aortic aneurysm, and tabes dorsalis. Neurosyphilis is special because it can happen at any stage and classically presents with Argyll-Robertson pupils, which accommodate but do not react to light. These are board favorites. Now let us go through high-yield stem recognition. For gonorrhea and chlamydia, the classic stem is a young sexually active patient with dysuria and discharge. The Gram stain result is your key differentiator, and remember, always treat both infections at the same time due to high co-infection rates. For syphilis, look for the painless genital ulcer, the diffuse rash including palms and soles, and positive rapid plasma reagin confirmed by fluorescent troponemal antibody absorption test. For genital herpes, the classic presentation is painful grouped vesicles on an erythematous base with recurrent episodes and prodromal tingling or burning. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 22-year-old man presents with a 5-day history of dysuria and purulent urethral discharge. He had unprotected intercourse 2 weeks ago. On exam, there is yellow discharge at the urethral meatus. Gram stain shows gram-negative intracellular diplococci. What is the most appropriate treatment? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. Young male, dysuria, purulent discharge, and gram-negative intracellular diplococci. That Gram stain finding is the classic identifier for gonorrhea. Step 2. Apply the rule. The board rule you must memorize is, always treat for both gonorrhea and chlamydia together because of high co-infection rates. This means dual therapy is the standard of care, never monotherapy. Step 3. Eliminate wrong answers. Azithromycin alone only covers chlamydia. Ceftriaxone alone covers gonorrhea but misses chlamydia. Penicillin G is for syphilis, not gonorrhea. The correct answer is C, ceftriaxone plus doxycycline. Here is our second practice question. A 28-year-old woman presents with a single painless genital ulcer that appeared 10 days ago. The ulcer has a clean base and raised firm borders. She has non-tender bilateral inguinal lymphadenopathy. She denies any pain or itching. What is the most appropriate initial diagnostic test? Think through this one carefully. The key word here is painless. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes a classic primary syphilis chancre. It is painless, has a clean base, has firm borders, and comes with non-tender lymph nodes. Herpes simplex virus culture would be wrong because herpes is painful, not painless. Zinc smear is also for herpes. Rapid plasma region is a great screening test, but it can be negative in early primary syphilis before the body has mounted a full antibody response. Now, why does dark field microscopy win? Because it can directly visualize the spirochete treponema pallidum, and it is the most sensitive test during early primary syphilis when serologic tests may still be negative. The correct answer is C, dark field microscopy. Let us review syphilis treatment for the boards, because this comes up constantly. For early syphilis, meaning primary, secondary, and early latent, the treatment is a single intramuscular injection of benzathine penicillin G. This is critical to know. Benzathine penicillin G is the only acceptable treatment during pregnancy. For non-pregnant patients with a penicillin allergy, doxycycline is the alternative. For late syphilis, meaning late latent and tertiary, you need 3 weekly injections of benzathine penicillin G. For neurosyphilis, you need intravenous aqueous penicillin G for 10 to 14 days. One more high-yield pearl. The boards love asking about the Jarisch-Herxheimer reaction, which is a fever, headache, and myalgia reaction that occurs within hours of starting treatment. It is caused by the lysis of spirochetes and is self-limited. Here is our third practice question. A 30-year-old woman has a routine cervical screening showing a positive high-risk human papillomavirus test with atypical squamous cells of undetermined significance on cytology. She has no history of abnormal screening. What is the most appropriate next step? This is a classic screening algorithm question. Think about what the human papillomavirus status tells you and how that changes management. We will walk through it next. Let us break down this answer. The classic pattern here is atypical squamous cells of undetermined significance, plus positive high-risk human papillomavirus in a woman over 25. This combination requires colposcopy. You should not delay further workup when human papillomavirus is positive. Now the key distinction. Repeating testing in 1 year is only appropriate when human papillomavirus is negative. A loop electrosurgical excision procedure is a treatment, not a diagnostic step, so it is premature here. Repeating cytology alone in 3 years is insufficient when human papillomavirus is positive. The correct answer is B, colposcopy with biopsy. Here is a critical test-taking pearl about screening and vaccination. For cervical cancer screening, remember these age cutoffs. Screening begins at age 21 with cytology alone every 3 years. At age 25, preferred screening switches to primary high-risk human papillomavirus testing every 5 years. Co-testing with cytology and human papillomavirus every 5 years is also acceptable. Screening stops at age 65 if there are adequate prior negative results. For human papillomavirus vaccination, it is recommended through age 26, with shared clinical decision-making available through age 45. Here is the important point. Vaccination does not change screening recommendations. The exam tests these age cutoffs and guidelines frequently, so commit them to memory. That wraps up our review of sexually transmitted infections test-taking strategies for Step 2 clinical knowledge. Remember to review the infectious disease and reproductive chapters in first aid in your question bank. Focus on the diagnosis, treatment algorithms, and screening guidelines we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.